Good morning, everyone. So good to see that before 6:30, especially northern India, part of India, it's still dark. People have joined. Already 30 people have joined. And within 5 minutes more, almost 60, 70 will join. So it's very nice and very encouraging to see that this lecture series is really required and everyone is taking it very seriously. So in continuation with the lecture series, by our post MD, our own post MDs from various parts of the country. This is the next lecture by Dr. Manisha. Dr. Manisha is our own resident at AIIMS New Delhi. She finished her MD and now she is a senior resident of Department of Palliative Medicine at AIIMS New Delhi. She is working sincerely. When I see in the wards, she is looking after patient very, very sincerely. And her communication is day by day improving with the patients. She has attended various conferences. Seems like since the day they have joined, all palliative medicine residents, they are looking forward to join various conferences and join ECHO platform, which Gayatri and the others are doing. So she has also presented various papers and posters in various conferences, and she take active interest in doing any sorts of research which is happening in the ward. So today's topic with the which Manisha is going to discuss is multiple sclerosis. Multiple sclerosis is a condition where I have seen patients that patient suffers, but they can't express, and they are always thinking why this has happened to me. So, but what is exactly happening? This every palliative care physician know that what exactly happens at the brain level and what is the physiology and what is the basics behind the multiple sclerosis and everything. Manisha will explain. And I have seen for this lecture, Manisha has really worked hard. At least she must have come 7, 8 times to me, and she has really worked hard. And let's see what she has brought today in this lecture. So go ahead, Manisha.
Thank you, ma'am. Good morning, everyone. Today I'll be discussing on multiple sclerosis. Next slide, please. So the outline of my presentation will be history, definition of multiple sclerosis, pathogenesis, epidemiology, type of multiple sclerosis, how to diagnosis, assessment tools, and treatment and symptom management, including the end of life care, and finally the summary. Next slide, please. The term multiple sclerosis was coined and defined by a French neurologist, Jean-Martin Charcot, in 1868. Next slide, please. So it is defined as an autoimmune disease of the central nervous system characterized by chronic inflammation, demyelination, gliosis, which will result in plaques or scarring, and the neuronal loss. It is the most common immune-mediated inflammatory demyelinating disease of the central nervous system. Mostly there will be multifocal areas of demyelination with loss of oligodendrocytes and the astroglial scarring. Next slide, please. Next slide. The exact cause of multiple sclerosis remains unknown, but evidence indicates that its pathophysiology includes two key and interconnected components, the neuroinflammation and the neurodegeneration. Next slide, please. So here you can see the antigens, like the antigens may come from the Epstein-Barr virus or HSV6 virus or any environmental trauma. Now, this antigens will be there inside the blood vessels. So the antigen presenting cells, it will present the antigens to the T cells. There will be a cascade of inflammation inside this. There will be cascade of inflammation, and these T cells, B cells, and monocytes, they will cross the blood-brain barrier and will come outside, and this will lead to the demyelination. There will be loss of oligodendrocyte and neurodegeneration. This demyelination will lead to the injury of the myelin sheath injury. Also, there will be a cascade of inflammation. There are inflammatory markers and also the anti-inflammatory cytokines. The anti-inflammatory cytokines include the TS2 cytokines, the interleukin 4, 5, 6, 13, and the inflammation, from the inflammation side, there will be interferon G, interleukin 12, 15, and 17. Apart from this, there will be B cells also, that is a humoral immunity that is also involved in this one. So there will be myelin antigens will be there, and it will be against, it works against the oligodendrocytes. There will be demyelination, loss of oligodendrocytes will be there, and does the injury to the myelin sheath. Next slide, please. Regarding the epidemiology of multiple sclerosis, India, the incidence is 8.3 per 100,000 population. The geographical, mostly the high frequency areas of world it occurs, but the prevalence is 60 per 100,000 population, including all the Europe, including Asian, Russian population, Canada and the North United States, New Zealand and the Southeast Australia. It is more common in women than the men, and the ratio is 2:1. And mostly the younger age group, the middle age group, 15 to 45 years of ages group is involved. It is also associated with higher latitudes in both the northern and southern hemispheres. Patients with multiple sclerosis, they have an average duration lifespan of 40 years after the diagnosis. Their life expectancy, however, just reduced by 7 years. So since the longer duration of duration is there from the time of drug diagnosis, there will be more symptom burden, and they need palliative. They are actually the real candidates for palliative care. Next slide, please. Genetic susceptibility like HLA-DR-B1 locus, it is also involved in this one. So any change in this locus will lead to the multiple sclerosis. Some viral infections like EBV, which causes infectious mononucleosis, varicella zoster virus, has been associated with it. However, CMV infection is associated with protection with multiple sclerosis. Exposure to sunlight may be protective because of an effect of UV radiations or of the vitamin D. Other factors include the tobacco smoking, obesity in children, but however, there is no association between vaccine and the risk of MS. Next slide, please. Now, the types of multiple sclerosis, it may be relapsing, remitting type, primary progressive, secondary progressive, progressive relapsing, and the clinical isolated syndrome. Next slide, please. Next slide. The relapsing remitting type multiple sclerosis, it is the most common type, which constitutes around 85%. It is characterized by the discrete attacks that evolve over days to weeks, followed by there will be some degree of recovery over weeks to months. As you can see in the diagram adjacent to it, like there is a recovery in between the acute attack, and so there will be no worsening of neurological function in between the attacks. The y-axis is the increasing symptoms or non-disability, and we can see like there is a complete resolution of symptoms in between the attacks. Now, primary progressive multiple sclerosis, it is characterized by steady functional decline from the onset of the disease, and there is no relapses. As you can see, there will be functional disability will continue in between there is no decrease in the functional disability. Secondary progressive is characterized by initial relapses followed by gradual neurological deterioration and not associated with acute attacks. And progressive relapsing is there will be steady functional decline from onset of the disease with later superimposed acute attacks. And PRMS or PPMS, they cannot be distinguished during the early stages until the relapses. However, the clinically isolated syndrome, it is like just there will be one episode of attack of multiple sclerosis, and there won't be multiple attacks. Next slide, please. Next slide. Now, how to make the diagnosis? The key principles includes the syndrome typical of MS-related demyelination, the objective evidence of CNS involvement, dissemination in space and in time, and the other, if we won't get any explanation and if the features are suggestive of MS, then we can make the diagnosis of MS. Next slide, please. Next slide. Now, the typical MS syndrome includes the optic neuritis. Mostly the optic neuritis is unilateral, which involves there will be blurring of vision will be then it is painful. And the brainstem syndrome, it involves, there will be trigeminal neuralgia can be there. There can be medial fasciculus may be involved. So there will be contralateral sixth nerve involvement will be there, and the ipsilateral third nerve will be involved. Cerebellar syndrome, it will lead to ataxia and transverse myelitis. It occurs in the spinal cord, where there will be loss of neurological deficit will be there at the level of lesion and also below the level of lesion. Next slide, please. Objective evidence includes the relative afferent pupillary defect. As in this diagram, we can see, like in the normal response is there, if you are putting the light torch on one side, there will be constriction of the another side as well. However, the positive RAPD of right eye, if you are putting the light on this right eye, but there should be constriction of this eye as well of the opposite eye as well, but there is dilatation. This is called afferent pupillary defect. They're also called internuclear ophthalmoplegia. So there will be diplopia, hemisensory level in a patient with history of transverse myelitis. There will be hyperintense optic nerve on MRI and T2 hyperintense lesion in the MRI spine. Next slide, please. So this is the Mcdonald's criteria for dissemination in space. So if one of the following is present in a patient with a clinical isolated syndrome or typical MS attack, there will be one or more hyperintense T2 lesions will be there, and at least 2 of the 4 MS typical regions, as the 4 regions are the periventricular, cortical or juxtacorticular, infratentorial, and spinal cord. Out of these 4, at least at 2 places these lesions should be there. And development of an additional clinical attack is characteristics of multiple sclerosis, and which should be supported by the objective clinical evidence that implicates a different CNS site. Next slide, please. This is the Dawson's. This is the most characteristic MRI which is present in the multiple sclerosis. Here you can see the Dawson finger. Actually, this is the areas of scarring, that is the plaques. Actually, in the periventricular region, there are the vessels, the veins. These are perpendicular in nature. So, and the sclerosis occurs in between the veins. So, just because of this, these are perpendicular. This appear as a Dawson's fingers. Next slide, please. And for dissemination in time. So, if one of the following is present in a patient with a clinically isolated syndrome or a characteristics MS attack, like there will be development of an additional clinical attack supported by objective clinical evidence, which I described earlier. An MRI or a spinal MRI of brain or spinal cord with simultaneous presence of the gadolinium enhancing or non-enhancing lesion at any time, or by a new hyperintense T2 lesions on follow-up MRI, irrespective of its timing with reference to a baseline scan. Also, these oligoclonal bands can be found in the CSF. Next slide. Now, for this 2017, the Mcdonald's criteria for the diagnosis with an attack at onset. So this can be described as either the attack is 2 or more than 2 clinical attacks, or 1 clinical attack. If there is 2 or more than 2 clinical attacks, we should look for whether the lesions with the number of lesions with objective clinical evidence or any additional data is required or not. If there is more than 2 lesions, then this is diagnostic of multiple sclerosis. If there is one lesion, then also there should be a clear-cut historical evidence of a previous attack involving a lesion in a distinct anatomical location. No additional data is required. But if there is just 1 lesion, then there should be dissemination, and in space should be demonstrated by additional clinical attack, which is implicating a different CNS site or MRI. If there is just 1 clinical attack, then the lesion should be either 2 or more than 2, and dissemination in time should be demonstrated by additional clinical attack or MRI, or demonstration of CSF specific oligoclonal band should be there. If just 1 lesion will be there, then there should be dissemination space, which should be demonstrated by additional clinical attack by implicating different CNS site by MRI, and there should be dissemination in time, or MRI, or there should be oligoclonal bands should be there in the CSF. Next slide, please. Next slide. These are the disorders that can mimic multiple sclerosis, though there are less, there are a number of differential diagnoses for multiple sclerosis, but two I would like to discuss, like ADEM, which is the acute disseminated encephalomyelitis. The differentiate point is like usually ADEM is preceded by a fever. There will be neck stiffness. Such features will be there, which is absent in multiple sclerosis, and also the lesions will be widespread. However, in the neuromyelitis optica spectrum of disease, there mostly the optic nerve involvement will be bilateral, and it will be bilateral, and also we will find the antibodies, that is a neuromyelitis optica aquaporin 4. These antibodies we can find in this CSF. Next slide, please. Assessment tools for measurement of quality of life in multiple sclerosis. So the tools which can be used for it are multiple sclerosis quality of life questionnaire, functional assessment of multiple sclerosis, Hamburg quality of life questionnaire, quality of life index, multiple sclerosis quality of life index, the Leeds multiple sclerosis quality, and the MS impact scale. Next slide, please. Management of MS involves treatment of the acute relapse, disease modifying treatment, and the symptomatic treatment. Next slide. For acute attack, the first line is the IV methylprednisolone. Usually it is given 500 to 1000 milligram daily for 5 days without an oral taper. Usually the onset is 2 hours of the effect and peaks by 12 hours. Side effects like mental status changes and psychiatric issues can be there. Plasma exchange is only in the second line of therapy. Usually 5 to 7 exchanges is recommended every 2 days, and the dose is like 30 to 50 milligram per kg who do not respond to glucocorticoids. Next slide, please. Actually, this DMT, the disease modifying therapy, it has evolved and come a long way. First, in 1993, it was just interferon 1 beta. Now we have come to the siponimod, which is a newer drug. Next slide, please. NHS, it has come with a treatment algorithm for the multiple sclerosis DMT, which was published initially in 2018 and updated in March 2019. Next slide, please. So for single clinical episode with radiological activity, if there is single clinical episode without MRI abnormalities, no treatment is required. However, if single episode with MRI abnormalities and which is fulfilling the Mcdonald's criteria, we can start with interferon beta 1A or glatiramar acetate. LM2-zumab, which is a CD5, which acts on the CD52, and ocrelizumab can be given and if the clinical or radiological marker indicate a poor prognosis for rapidly developing permanent disability. Next slide, please. For first-line therapy, if the RRMS, the two significant relapses are there in the last 2 years, interferon beta, dimethyl glatiramar, and teriflunomide can be given, and LM2-zumab or ocrelizumab can be given. This should be noted, like there is no any, we don't go for usually the combined therapy, and one can be used by the other, seeing the side effects and like teriflunomide, it is teratogenic, so it should not be given in a pregnant female. Dimethyl fumarate, it is toxic to the liver, so if the patient develops liver toxicity, so we should stop this dimethyl fumarate. However, the good point in dimethyl fumarate is it is oral, so we can give orally to the patient. And RRMS is if this is one relapse in last 2 years and radiological activity is there, interferon beta 1 and glatiramar acetate should be given, and same like elotuzumab and ocrelizumab can be given. For rapidly involving LM2-zumab, ocrelizumab, and cladribine and natalizumab can be given. Next slide, please. So if the patient is intolerant to the for the first line therapy, and same by RRMS, there will be 2 significant relaxes, interferon beta, glatiramar, teriflunomide, and elotuzumab can be given. And you can see the alternative therapy can be teriflunomide, glatiramar, same thing. And for RRMS, one relapse in last 2 years and there is radiological activity, interferon beta 1A, glatiramar acetate, ocrelizumab, And for alternative, interferon and glatiramer can be given. If there is rapidly evolving, there is cladirbind, LM2zumab, natalizumab, and then fingolimod. If alternative, this is also the first line therapy, fingolimod, but fingolimod is actually approved in the pediatric age group. Next slide, please. Now for second line therapy with disease activity on the first line. Actually, second line therapy, if you will go through this slide, you will think that the first line of drug is almost similar to the second line of drug. This is just because if there is no any clear cut, like this should be used alternative to this, but according to the side effects, if patient develops some side effects during the first line of therapy, then we can change to the second line of therapy. Then for rapidly involving severe MS, same like the DMT will be almost the same. If the patient develops the side effects in the first line, then we can go to the second line of therapy. Next slide, please. For the disease activity on second line, the third line usually there is no much change. Only in the third line of therapy we are using the autologous hematopoietic stem cell transplant, and for same for rapidly involving, we can go for autologous hematopoietic stem cell treatment as a third line of therapy. Next slide, please. Now, treatment algorithm for relapsing progressive multiple sclerosis, only interferon beta 1b is approved by NICE for relapsing progressive disease. And the starting criteria is all the following should be made, like it has at least 2 disabling relapses in 2 years, is able to walk 10 meters or more, the EDSS should be less than 7, and he has a minimal increase in the disability due to progression over the past 2 years. He should be more than 18 years and has no contraindication. Stopping criteria is there should be no reduction in the frequency or the severity of relapses compared with the pre-treatment phase following a minimum of 6 months period, intolerable adverse effects of the drugs, and development of inability to work and persistent for more than 6 months and unable to work for reasons other than MS. And it should be stopping criteria should be discussed with the patients and agreed before treatment is begun. Next slide, please. As far as Indian context is concerned, we should always look whether it is multiple sclerosis and it should be multiple sclerosis or it is some other neurological disease, or what type of MS. If it is RRMS, then if it is an acute onset, we should look for the methylprednisolone, and if it is a clinically isolated syndrome or significant MRI changes are there, then and we should start the DMT with beta interferon or the glatiramer acetate. And if there is good response, then the beta interferon and glatiramer should be continued, or if there are some continued relapses and adverse effect, natalizumab should be considered. And if the patient cannot afford the therapy, as usually happens in India or some poor or medium economic group, then we should look for methotrexate, which is an oral drug, and azathioprine should be used, which is off-label drug. Next slide, please. And monitoring the response to therapy, there should be a clinical follow-up. If there is any acute attack, there should be cognitive assessment. EDSS should be there in every 3 months, and MRI every 12 months, and modified Rio score. This thing I will discuss afterwards. The next slide. Please, next slide, please. So this is expanded disability status scale, where 0 is the normal person, 9 is the bedbound, and 10 is the death patient. Next slide, please. This is a modified Rio score, which involves the criteria of MRI and relapse. However, the original Rio score, it is having the EDSS criteria as well. So if MRI, it is 4 or less than 4 new T2 lesions, the score is 0, more than 4 new lesions, it is 1. According to relapse, it is no relapse, then 0, 1 relapse is 1, and 2 or more than 2 relapses, score is 2. Next slide, please. So we should always look for the modified Rio score. There is no relapses or there is any substantial any new T2 activity, and if the Rio score is 0, we should consider that patient as a responders. If the modified Rio score is 1 and there is 1 relapse or no relapse, and there is new T2 activity, So if there is no relapse and less than 2 T2 lesions, there should be responders. If more than 1 relapse or more than 2 new T2 lesions, they should be considered as non-responders, as well as the Rio score of 2 to 3 and more than 1 relapse or 1 relapse and substantial new T2 activity, they should be considered as non-responders, and we should go for other DMT for this patient. Next slide, please. And these are the new and emerging immunotherapeutic strategies like the multipotent hematopoietic stem cells, BST3009, which is a DNA vaccine, and some nanoparticles have been developed, and altered peptide ligands, cyclic peptide, and mannan, which acts as a carrier to modulate the immune responses. Next slide, please. And some remyelination agents, these are have been found, which has shown some effect, like benztropine, which is an anticholinergic, or opicinumab, which is an anti-lingo-1, clemastine, which is antihistaminic and anticholinergic properties, and high-dose biotin, as it helps in myelin biosynthesis, and elezanumab, which is an anti-repulsive guidance molecule antibody. Next slide, please. The symptom burden in multiple sclerosis, it is like a tip of the iceberg, what people see. Like we can see the walking difficulties, speech problem, and tremors. But what people do not see is the pain, fatigue, spasticity, numbness, vision problem, bowel and bladder disturbance, cognitive difficulties, emotional changes, swallowing and breathing difficulties, psychosocial and the financial issues, as this drug are very costly, spiritual, and the existential distress. Next slide, please. So if the CNS symptoms involved, as I told earlier, like there will be fatigue, cognitive depression, and the mood swings will be there, visual problems will be there, speech like dysarthria, throat, they will be having difficulty in swallowing, dysphagia will be there, weakness, spasm, ataxia, pain, hyposthesia, and bowel bladder issues will be there. Next slide, please. So, so much symptom burden in such patients. So the patient's holistic care, it needs the involvement of a neurologist, a palliative care physicians, nurses, psychiatrist, urologist, psychologist, vocational counselor, occupational or speech therapist, social worker, and NGOs, and the physiotherapist as well. Next slide, please. So we'll just see each symptoms and what we can do for that patient. So fatigue is actually multifactorial in these patients, and it is the most common symptom in patients with MS. 80% there is lifetime prevalence. So we should look for what medications the patient is taking. We should limit the sedating medication, screen for depression, obesity, OSA, anemia. And we should encourage patients for energy conservation measures. Regular exercise regime should be advised to them. Depression is usually the 30%, there is point prevalence, and it is associated with higher EDSS score and anxiety. We should treat with CBT, SSRIs like the escitalopram, citalopram should be advised to the patient. SNRI should be given like duloxetine. We can start with 30 milligram per day to the 120 milligram per day. We can go for it. And also we should choose the treatment strategy depending on the depression severity and the side effect profile. Pseudobulbar effect, like the patient will be involuntary crying or laughing, which is disproportionate or inappropriate to the social context. For this, we can give dextromethorphan and quinine. It comes as a drug as a combination, and 1 tablet 2 times a day can be given. Tricyclic TCA is like nortriptyline, and nortriptyline can be given to these patients. Like we can start with 25 milligram per day to 150 milligram per day. SSRIs and SNRI can be given. Next slide, please. Sometimes the patients have the paroxysmal symptoms like trigeminal neuralgia, Ledmid's sign, and tonic spasm. This Ledmid's signs I will explain afterwards in the upcoming slide. And mostly they will be sensory with variable motor involvement, and duration is 1 to 90 seconds. The drugs used for this are the sodium channel blockers like carbamazepine, 200 milligram 2 times a day. We can start with this one. And oxcarbazepine, carbazepine, carbapenem. Lacosamide is a new drug. If it is unresponsive to all these drugs, then we can use lacosamide. There's limited evidence for this, and 100 milligram per day can be considered as a second line. Cognitive impairment, like it can occur in any stage, even in the clinically isolated syndrome. Prevalence and severity is higher in patients with progressive MS, and it can even occur in the absence of accumulating T2 brain lesions. So we should, for this also, we should look for the patient is addicted to tobacco use or polypharmacy, depression, and all other like sleep distress and other related factors. We should rule out the other causes of cognitive impairment. Use of diaries, calendars, and regular physical exercise and regular social contact can help these patients. There is no evidence for any efficacy of acetylcholinesterase until and unless the patient is having the Alzheimer's type of dementia. Next slide, please. Temperature dysregulation, usually most common in patients with high EDSS scores. The symptoms is the Uthov's phenomena, in which the symptoms of MS will aggravate when the patient will be exposed to temperature. Occurs in the recurrent increase in the prior MS symptoms. There may be encephalopathy, pupillary dilatation, and thrombocytopenia. The patient should be counseled regarding the maintenance of adequate ambient temperature, wearing adequate clothing, and ACs can be used for such patients. And spasticity is usually driven by the brainstem and the spinal cord disease, and mostly the patients report pain and leg spasm, mostly in the night and after the periods of immobility. Stretching exercise, baclofen, tizanidine, and the gabapentin can be used. Oral cannabis extracts and the synthetic tetrahydrocannabinol or oral napiximol sprays are also available. Diazepam or dantrolene can be act as a third line drug, but they have toxicities, so mostly they are not used. And for non-ambulatory patients, we can go for intrathecal baclofen pump, but again this should be discussed with the family members according to their preferences. Next slide, please. Gait dysfunction, maybe in these patients we can go from the ankle foot orthosis and gait aids, and that dalfampridine has also been found to be used in this gait dysfunction. Tremor and ataxia, there should be physical therapy to compensate for ataxia, but usually these are refractory to medication, so we can go for deep brain stimulation surgery, maybe consider for if it is severe disabling tremor. And for dysphagia and all, there should be careful feeding and soft food should be given to the patient. Decision of artificial nutrition with gastrostomy, it should discuss with the patients according to their goals and preferences. And dysarthria, there will be speech and language disturbance can be there. So in these cases, augmentative and alternative communication systems ranging from the simple spelling boards to complex computer-based systems can be used. Vertigo and dizziness response to gabapentin and memantine can be given. Memantine is an NMDA blocker, so we can give in these patients. Seizures, as per the non-multiple sclerosis population, depending on the type of seizure and epilepsy, management should be done. Next slide, please. Bladder dysfunction is common in MS and usually present as a urinary frequency and urgency, or there may be mixed, which is exacerbated by the constipation and the obesity. And urine analysis should be done for this patient. Conservative management is mostly preferred, like fluid restriction at night. We should schedule the voiding and avoidance of caffeine and tobacco. Post-viral, if urine is more than 100 ml, we should consider for intermittent self-catheterization. If it is less than 100 ml, then we should give the anticholinergic medications like oxybutynine, trospium, and darifenacin should be preferred. Third line treatment includes the intravesical botulinum toxin injection, tibial nerve stimulation, and surgical interventions in selective patients only. Usually the sexual dysfunction, the less we talk about it, but however, data shows that it affects up to 90% of the patients. Erectile dysfunction is common in men, which can be treated with phosphodiesterase inhibitors. However, this anorgasmia, reduced vaginal lubrication, and reduced libido are common in women. And lubricants and moisturizers can be treated with lubricants, moisturizers, and vibrators. Next slide, please. Pain is prevalent in 63% of the populations and headache in the 43%. Neuropathic extremity pain in 26%. However, 20% patients have backache, 16% have Lermit sign, and painful spasm in the 15% patient, and trigeminal neuralgia in 4% of the patient. Next slide, please. The cause of pain is maybe directly related to the disease process, such as central pain due to corticospinal inhibition or chronic activation or nociceptive afferents, or maybe due to complications of disease such as spasticity and contraction, and maybe secondary to the pharmacological treatments, as we know that steroids are given in these patients, and this may lead to the pathological fracture, or the beta interferon can be used, can exacerbate the migraine. Spasticity is common in patients with MS. Next slide, please. This Lermit sign is, it is a sensory sensation usually lasting for seconds, and it is electric shock line which is radiating the spine into the radiating to spine, and it is mostly elicited by the flexion of the neck, often resolved spontaneously without treatment, and glucocorticoid therapy may abolish the pain. Mac-Adler sign is, it is a reversible gait dysfunction and increased weakness induced by neck flexion, and in patients with multiple sclerosis who may have the cervical demyelinating lesion. MS hug, also called as the anaconda sign, which is due to the dysesthetic phenomena, which manifests with gripping, squeezing, constricting, or pressure-like lesions in the thoracic and the abdominal lesions. Next slide, please. Management of pain in multiple sclerosis, we have the non-pharmacological management as well as the pharmacological management. Next slide, please. Non-pharmacological management includes the exercise, yoga, neuropsychological interventions such as the CBT, acupuncture, and interventional procedures like TENS, transcranial direct current stimulation, and spinal cord stimulation. Pharmacological management includes the cannabinoids, which is present in the oral, mucosal form, smoked, and the vaporized form. Muscle relaxant like tizanidine, baclofen, and dantrolene can be given. Anticonvulsants like benzodiazepine, clonazepam, diazepam, gabapentin, pregabalin, and carbamazepine, and lamotrigine can be given. Antidepressant like duloxetine, TCAs should be given this for the management of pain. Botulinum toxin can also be given as if the pain is due to the spasm. Anti-inflammatory like NSAIDs and steroids can be considered. Next slide, please. So, is there any role of opioids in the management of pain in multiple sclerosis, as we use this opioids day to day in our OPDs? Next slide, please. So, opioid analgesics often provide inadequate relief for MS patients, except at high doses that might enhance the risk of adverse effects. Next slide, please. So, this was one article which was recently published in September 2021, which shows that endogenous opioid peptides have they bind to mu opioid receptors, kappa, and delta opioid receptor, and they have some immunomodulatory molecules within both the immune and the nervous system. And dysregulation of the opioid system is a mechanism that contributes to the pathogenesis of MS and associated symptoms. And they have found like there is less evidence like lower dose naltrexone therapy, 1 to 4.5 milligram. It acts as an immune modulator by reducing the inflammatory glial response. Next slide, please. What regarding the immunization? So first, the patient should be counseled regarding the disease status, and also the patient should be and the immunization, and also the patient should be screened for latent infections, as this DMTs reduces the immune system of the patient. Vaccinations like vaccinations should be considered for varicella zoster virus and hepatitis B. They should be given 4 to 6 weeks before initiating the DMT. If the patient is receiving the DMTs, life attenuated vaccine should be avoided. And those who are experiences a relapse, so vaccination can be delayed until the relapse has resolved. Regarding the SARS-CoV-2 vaccine, it should be given prior to commencing therapy, and there should be, if the vaccination has to be given and the treatment has started, there should be arranged a cycle in the treatment when immune response is likely to be maximal. Next slide, please. What are the unmet needs of severely affected multiple sclerosis patient? This article actually was published in 2011, old one, but this will give you an insight like what are the needs for the patients as well as for the healthcare professional. Next slide, please. So actually they have categorized it into 4: support from family, friends, healthcare services, managing everyday life, and managing the biographical continuity. And again, they have subcategorized it. As in the lower side, you can see here that the one which is white in color, they are the unmet needs, which is mentioned both by the patient as well as by the healthcare professionals, like emotional support, access to services, competence, treatment options, the relationship between patient and the doctors. All these things are in white color, who have where there is a consensus between patients and the healthcare professionals, while the dotted one, in which there is subcategories of unmet needs by the healthcare professionals were there, but not by the patients. However, that cross lines, that is accommodation and leisures, these were the needs which were mentioned by the patients, but they were not mentioned by the healthcare professionals. Next slide, please. Spiritual well-being in MS helps as a coping strategy and acts as a protective shield against stress-induced illness and even the complications of treatment. Spirituality actually is defined. This definition was given in 2009 by the National Consensus Conference report as the aspect of unity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, self, others, to the nature, and to the significant or sacred one. Next slide, please. Next, as these drugs are very costly, so there are a lot of financial toxicity in the multiple sclerosis. So this was the article which was published last year in 2020, which in which like they have mentioned that multiple sclerosis patients with lower financial efficacy and prior relapse history, they are at higher risk of financial toxicity and non-adherence, and which will decrease the lower health-related quality of life. Next slide, please. So what are the challenges that need to be addressed, like long and unpredictable duration? As I told you, from the time of diagnosis, the duration is around 40 years. Wide range of symptoms, complex multidisciplinary care issues, and neuropsychiatric problems like behavior and the cognitive changes, which will negatively affect the communication and care planning. Next slide, please. Barriers include the palliative care specialist. We are more trained in the palliative issues of cancer patients, and we have the limited capacity and lack of disease-specific knowledge. Neurologists also might not always see a role for palliative care in their complex patients, and associate palliative care with death and dying, and are afraid to diminish patients' hope by introducing palliative care. Patients also think that they are reluctant to accept a referral, as they have long-standing relations with their neurologist and who are providing them service for a long time, and they also consider that association with palliative care is synonymous to end-of-life care. Next slide, please. How we can help? The key to effective palliative care is communication. Basic tenets of palliative care include providing relief from pain, any shortness of breath, nausea, or other distressing symptoms. So it is essential to ensure that patient with MS is able to understand as much as he or she wants to know about the disease, and to be aware what may happen in his or her disease progress. So the intent is to neither hasten or postpone death, but instead to offer a supportive system to help patients to live as fully as possible through the integration of medical, biopsychosocial, and spiritual aspects of patient care. Next slide, please. The serious conversation which may trigger in patients with advancing multiple sclerosis by different stages of disease. Like we have in the earliest stage itself, it's a trigger point at the time of diagnosis. If there is malignant multiple sclerosis, hospitalization or time of relapse, or if we are escalating the immunomodulatory therapy to more aggressive therapy, which have the more risk and more complication. Also, during the advances, disease triggers having to stop or change work during the growing disability. If the patient is loss of ability to drive, development of any chronic pain, or if there is relationship crisis, loss of ambulation and adaptation to wheelchair, urinary incontinence, or the patient is having the cognitive or communication dysfunction. Later stage, it can be due to the advancing cognitive dysfunction, also the transfer from hospital care to the residential care. And if you are de-prescribing the neuroimmunomodulatory agents, also there is dysphagia, so there will be risk of aspiration, reduced nutritional intake. The recurrent infection and repeated hospitalization for comorbidity, these are also the triggering factor in the later stage of disease. Next slide, please. Now, approaching the end of life care, the timing of and the triggers for serious in-link conversation is influenced by the stage of the disease. So we should be vigilant and attentive to the needs of the patient and family. The multidisciplinary care team will be best positioned to transition the patient and family to appropriate terminal care, referring to a preferred place. It may be a home or a hospice according to the patient preferences and his or her caregiver preferences. Education about the course of the expected terminal signs and symptoms, adjusting medication and treatment as appropriate, addressing the spiritual and cultural concerns when preparing the family for death, and providing the appropriate support. Next slide, please. And this was the RCT which was done in Germany, and which they have found that the home-based palliative approach has reduced the symptom burden. However, there was no change in the quality of life. Next slide, please. Now, actually, caregivers are the superheroes in the life of patient. So supporting a caregiver is very important. So caregiver health status like physical, emotional, and mental, as their own health issues may affect their ability to care long-term for their loved ones with MS. Burden increases as the disease duration increases and the handicap and with the increasing handicap. So bereavement, and also we should provide the bereavement after the loss of loved one. Next slide, please. So summary is MS are not amenable to curative treatment and exact etiology is unknown. The long and uncertain time course, uncertain disease trajectory increases the symptom burden and decreases the quality of life of patients as well as their caregivers. So the key of palliative care is communication, prognostication, and symptom management. Redefining goals of care during disease trajectory, from control of disease, as we know that cure is not possible, to end of life care can smoothing the whole journey. Next slide. So the future, like there should be a bi-directional educational efforts between the neurologist as well as the palliative care physicians. We should define the appropriate time to discontinue medications in advanced disease, improving our evidence base for symptom management at end of life, and also exploring the costs, benefits, and effectiveness of various models of end of life care. Next slide. So these are the references which I have used. Next slide. Thank you. Thank you.
Thank you, Manisha. Thank you very much. So I think it is now we can ask Arun, are there any question? I can see one question: anesthetic implication of multiple sclerosis. Is the only question?
Is the only question, ma'am. Yes.
So are there no question from others? All palliative medicine doctors, do you know everything about multiple sclerosis?
It was a very good presentation, I must say.
It was a very good, and she worked hard. Can I ask everyone to open their video, please? So, or if they are not very uncomfortable. So I think Dr. Vasanta, you have asked about the anesthetic implication. I can answer this because I don't think Manisha will be able to answer. Because this is basically a motor neuron degenerative disorder. And we have to be very careful in giving, first of all, our pre-anesthetic checkup should be very, very thorough. In that, we have to see how much already the nerve damage or the deficit has already happened, and everything should be documented. And mostly it will be general anesthesia. If at all your person is planning to give regional anesthesia or planning to use local anesthetic, we have to be sure that it should be in the lower side. Dosage should be on the lower side. Second thing, when we are giving relaxant, then also we should use neuromuscular block, neuromuscular monitoring definitely, because again, and doses of neuromuscular agent has to be very, very low. Third important, very important thing that we should know the drug interaction, because they are on a lot of drugs. So it is important that we should have a very good idea that what are the medicine the person is already taking, and we should be very careful in giving the drugs. So I think these are the anesthetic implication person should know when they are giving anesthesia to a patient of multiple sclerosis. For example, if a multiple sclerosis patient has come with carcinoma, and already Manisha has explained that they survive almost for 40 years, sometimes they survive. So it is not that patient person, because she is having multiple sclerosis, so she should not be operated. She need to be operated, and we have to give anesthesia. So all these things we should be having a good idea that how to give anesthesia to this patient by using your own senses. And there is also one very important thing which we have to be careful with, that the temperature dysregulation happens very fast in multiple sclerosis patient. It is not hypothermia, it is hyperthermia which creates the problem. So we have to be very careful. So there are 4 points. If you have to be very thorough in your pre-anesthetic checkup. You should use your local anesthetics judiciously, very low doses. Neuromuscular blocking agent has to be very low, and you should use neuromuscular monitoring whenever you are using, and you have to be very cautious about the temperature control. Dr. Vasanta, have you received your answer?
Yes, madam. Yes, madam. Thank you, madam.
Okay, so anyone wants to know anything else? So everyone
Yes.
says that, yeah,
Question.
go ahead, Arun.
Question, yes. Manisha, one question for you. How to address parents' concern on multiple sclerosis risks in other siblings? Can it be hereditary? Should the other kids in the same family be screened for multiple sclerosis, or any need for genetic counseling?
Like there is actually a DRB1 gene is there. So if there is some changes in that HLA-DRBF gene, so there is genetic susceptibilities there. But however, as well as India is concerned, we have very low incidence of low incidence of multiple sclerosis. It is just 8.3 per 100,000 population. So if the others if any other family member is having such symptoms, if develops, then only we should go for then they should further evaluate for the multiple sclerosis.
I think iska answer again, Rabia. I don't think that maybe we can find out from neurologists, because we have no idea that whether there is genetic counseling. There is a strong genetic predisposition in this multiple sclerosis. Maybe Manisha, have you read this in any of the literature that there is a genetic predisposition in multiple sclerosis? Because I haven't seen that multiple sclerosis patient doctors are asking that your brother and sister can have and you should have a. So I'm not sure, but we should find out from the neurologist and then only answer this.
I will try to find out, and if something
Post
like
the
this, I guess I will post
answer
it.
to Arjuna. She will send to everyone.
I will send it in group.
Okay,
So,
thank you. No more questions for today. Thank you.
No more questions. So we have 7 minutes. It is going to be difficult that we will get multiple sclerosis patient regularly for palliative medicine consultation, because multiple sclerosis patient, usually neurologists think that they should be cured. No, so they should be treated by themselves, and rarely we will get consultation for these patients. But when Manisha was explaining the whole lecture, we have seen that there is so much need of patients, those who are suffering with need of palliative care in the patients, those who are suffering with the multiple sclerosis, and especially the most biggest sufferer are the caregivers. So it is important to take care of the patient, their symptomatic needs as well as the caregivers needs. So there is a strong requirement of integration of palliative medicine in these patients, and we should try wherever we are working we should try to talk to the neurologist of your hospital, that because many times neurologists, they themselves know that how a palliative care physician can help us. When we saw 2 patients of multiple sclerosis in neurology department, it is such a big hospital, and when we saw after a long time, ultimately needs was realized, and when we saw, and means like it was quite a satisfactory experience for us, and then as well as it was a great help for neurology department as well. So it is not that we are going to treat these patients in the initial stages, but as our counseling skills, we should be good. Definitely our communication skills should be good, because patients are going to ask, because most of the time they are in their young stage, so they are going to ask that why this has happened to me, because because as soon as they've been diagnosed, their life is going to be compromised. Means like they will not be able to do the daily activities which they were doing before, and what other their peers are doing. So it is a very a difficult job to handle these patients, and they will keep asking you why this has happened to me, why my sister is doing so well and why I'm not doing so well, my brother is doing so well, I am unable to walk, I am unable to, my parents are looking after all the time to me, and there are going to be a lot of questions, and it is difficult to answer. So if palliative care physician will get involved, definitely in early stage it will be help. And as the disease will progress, we can't say that it will be all the patients will survive for 40 years. But as the disease will progress, I think if palliative care physician means a patient who is coming for follow-up with neurologist, and if a palliative care physician will also see, the person or the patient will have an idea that both the doctors are my doctors. And when the real end will come, I think it can be a very good, smooth transition to end of life. So it is important. And I'm telling again, I with experience, I'm telling you that wherever you are working, you have to take the lead, because it is not that neurologist will come and tell you that please come and help our patient of multiple sclerosis. You will have to take lead, and repeatedly you have to give you do efforts to to go and talk to these neurologists, that we can take care of your patient in such a way. So without having any I think without having any, I should say that ego problems, or we should go and try to help our patients, those who are suffering, even in neurology department with multiple sclerosis. So Manisha, it was excellent presentation. I know that it is whatever topics these days our residents are taking, post-MD people are taking, I think they are rare diseases. They have not seen they are not seeing these patients regularly. Still they are taking, and they're trying their level best to explain them. So it is commendable, and we can say, and the future of palliative medicine is really bright. I'm really happy to see all this.
Thank you.
Thank you very much. Have a nice week, and we will see you next Monday before 6:30.